Hello, everyone. Thank you for joining us today for the CMS OASIS Guidance Updates webinar. My name is Haley Burnside, and I will be your host and moderator today. This presentation has been prepared to support home health agencies in their OASIS data collection efforts. All content presented is current as of the date of this training. Our presenters today are Jemima Keys, Linda Krulish, and Megan Bernier. Jemima Keys is a registered nurse with a Bachelor of Science in Nursing. Jemima is the OASIS coordinator for the CMS Home Health Quality Reporting Program. She has over 2 decades of experience in the nursing field, including the intake coordination for home health and hospice. Linda Krulish is a physical therapist with a master's in health sciences. Linda is CEO and founder of OASIS Answers, Inc. in Redmond, Washington. She has worked in the home health industry since 1988 and is a nationally recognized presenter and expert on OASIS, quality measurement, and quality improvement. Linda provides oversight and subject matter expertise to support CMS quality reporting program contracts for home health, hospice, inpatient rehabilitation facilities, long-term care hospitals, and skilled nursing facilities. She also oversees OAI's support for the CMMI Home Health Value-Based Purchasing Technical Assistance Contract. Megan Bernier is a physical therapist with a master's in physical therapy. Megan is a post-acute care clinical manager for OASIS Answers, Inc., where she supports the CMS Quality Reporting Program contracts, developing provider education, guidance manuals, and providing day-to-day management of the CMS help desk that support data collection of OASIS, the MDS, and the IRF-PI and the LTEC care dataset. She has worked in the home health industry since 2010 as a field clinician, as well as in supervisory and administrative positions supporting quality and compliance. Megan holds the certificate for OASIS Specialist Clinical designation and is a knowledgeable and passionate national OASIS educator. It is now my pleasure to turn the session over to our first speaker, Jemima Keys.
Hello, everyone, and thank you for joining us today. As we are sure most of you are aware that the OASIS instrument was scheduled to be updated, transitioning to OASIS E at the beginning of 2021. Due to the COVID-19 public health emergency, the OASIS E implementation has been delayed. Currently, agencies are using the OASIS E guidance manual to support OASIS data collection. This manual became effective on January 1st, 2019. And contains valuable guidance on coding the OASIS items based on information gathered during the comprehensive patient assessment. Since the publication of the guidance manual, there have been multiple quarterly Q&As published, containing clarifications resulting from questions submitted to the Home Health Quality Help Desk. Typically, these quarterly Q&As are integrated into the next version of the guidance manual. Since the OASIS E delay has also caused a delay in the release of the OASIS E guidance manual, CMS wanted to take this opportunity to highlight some of the more significant OASIS guidance refinements that have been made available in the recent quarterly Q&A releases. We are referring to this guidance that has been published between manual releases as interim guidance. Please note that this webinar is not intended to provide basic or comprehensive OASIS training. Providers are directed to the posted OASIS guidance manual, Q&As, and posted provider trainings to meet the needs of the clinicians new to OASIS or those seeking a more general overview. Links to these essential OASIS resources are available at the end of today's presentation materials. Upon completion of this webinar, we hope you will be more familiar with these newer OASIS clarifications and that you will feel confident in applying the guidance as you complete your patient assessments or educate your clinical staff. Today's training is advanced and is specifically intended to support home health clinicians who have a good foundational knowledge in OASIS data collection and guidelines, and who are specifically looking for an overview of important OASIS data collection clarifications recently released by CMS. The target audience for this webinar are those with a working familiarity of the OASIS items and coding guidance as outlined in the guidance manual and posted Q&As. For your reference, we provided a slide with a list of acronyms used in this webinar. During the webinar today, we will review OASIS guidance updates to several OASIS items as well as reviewing some important refinements to general guidance for the GG self-care and mobility items. At the end of the webinar, we will address questions that were previously received. If you have any questions during or following today's webinar, you are invited to submit them to the Home Health Quality Help Desk at homehealthqualityquestions@cms.hhs.gov. I'll now turn the presentation over to Linda Krulich. Linda?
Thank you, Jemima. Hello, everyone. The first OASIS item that we'll be covering today is M1033, Risk for Hospitalization. This section of the webinar is intended for learners who have a good working knowledge of this OASIS item, including how each response option is defined and what the time periods under consideration or the lookbacks are for each response option. At the beginning of each new section of today's webinar, we have included a graphic of the OASIS items that we'll be discussing. M1033 is used to identify the presence of patient characteristics that may indicate that a patient is at risk for hospitalization. Today, we're going to be focusing on some refined guidance for response 3, multiple hospitalizations, 2 or more in the past 6 months. Response 4, multiple emergency department visits, 2 or more in the past 6 months. Response 5, decline in mental, emotional, or behavioral status in the past 3 months. And response 7, currently taking 5 or more medications. So let's start with response 3. Response 3 is used to indicate if the patient has had multiple hospitalizations, again defined as 2 or more in the past 6 months. To accurately code this item, we need to understand how hospitalization is defined. In the October 2019 CMS OASIS quarterly Q&As, specifically questions 13 and 14, there was updated guidance published that provided more definitive details on what can be considered a hospitalization for this response. First, the guidance from question 13 directs us to only consider acute care hospitalizations. This means that stays in other hospitals that are not acute care, like an inpatient psych hospital or a long-term care hospital, would not count when reporting multiple hospitalizations. Question 14 provides even more definitive guidance to determine if a stay in an acute care hospital can be considered here. The Q&A states that to be considered an acute care hospital stay, a patient must have been admitted to the acute care bed for 24 hours or longer, and for reasons other than just diagnostic testing. This means that if a patient had an observation stay in a hospital in the past 6 months, that would not be included as a hospitalization since the patient wasn't admitted as an inpatient. You'll note that in the footer of the slides, we've included the reference to questions 13 and 14 from that October 2019 quarterly Q&A document, just in case you'd like to review the complete guidance references. And you'll find the relevant source Q&As in the footers throughout the presentation. And the web address where those quarterly Q&A documents are posted is available at the end of the presentation. M1033 response 4 is multiple emergency department visits, and it's coded when the patient has had 2 or more emergency department visits in the past 6 months. New clarifications instruct providers to only consider visits made to a hospital emergency department. If the patient receives services from an urgent care center or a walk-in clinic, these would not count towards the 2 or more emergency department visits that are referenced in response 4 because they're not hospital emergency departments. Response 5 is coded when a patient experiences a decline in mental, emotional, or behavioral status in the past 3 months. Clinicians should consider any such decline, whether it's temporary or permanent, and regardless of the cause of the decline. The decline can be reported by the patient themselves, or by a family or caregiver, or by the patient's physician. But reporting this decline does not require physician consultation or treatment. Response 7 reports if the patient's currently taking 5 or more medications. When determining the number of medications that a patient is currently taking, clinicians should consider all prescribed and all over-the-counter medications, as well as any nutritional supplements, vitamins, homeopathic medications, herbal products, TPN, and oxygen. Consider medications that are administered by any route. New guidance clarifies that the number of medications that a patient is taking is determined based on the meds that are listed on the reconciled medication profile. The next slides will cover guidance updates specific to two of the pressure ulcer injury items, M1306, which is unhealed pressure ulcer injury at stage 2 or higher, and M1311, which is current number of unhealed pressure ulcers or injuries at each stage. Again, this presentation is intended for learners who already have a good working knowledge of these OASIS items, including how to stage pressure ulcers and injuries, the definitions of each stageable and unstageable pressure ulcer injury response option for M1311, the definition of present at the most recent start of care, resumption of care, and coding guidance for M1311 at the various OASIS time points. M1306, unhealed pressure ulcer injury at stage 2 or higher, is a yes or no item, and it identifies if the patient has at least one pressure ulcer, that's a stage 2, a stage 3, or a stage 4, or unstageable due to a non-removable dressing, due to slough or eschar, or a deep tissue injury. M1311, current number of unhealed pressure ulcers or injuries at each stage, reports the number of pressure ulcers, stage 2, stage 3, stage 4, and unstageable pressure ulcers or injuries that are observed on assessment. At the discharge time point, M1311 also identifies if each pressure ulcer or injury that is present on the discharge assessment was also observed at the same stage at the time of the most recent start of care or resumption of care. The guidance manual and Q&As include a lot of guidance about coding these pressure ulcer and injury items. In order to highlight the new guidance clarifications, we'll need to assume our listeners are familiar with the existing pressure ulcer injury items and guidance, and we'll highlight some of the new clarifications intended to enhance data validity and standardization. When determining the accurate response for pressure ulcer injury items at the start of care and resumption of care time points, there is specific guidance on what assessment source can be used. Code the pressure ulcer injury items based on the first skin assessment that's conducted on or after, but as close to the start of care or resumption of care date as possible. Even if a pressure ulcer or injury changes from one stage to a higher stage during that assessment time frame, the OASIS would still be coded based on what was identified when the first skin assessment was completed. For example, if on my first skin assessment on day 1, I see a stage 2 pressure ulcer, that is what I should code on my start of care OASIS, even if that stage 2 worsens to a stage 3 by day 3 or 4. This guidance is also the same for unstageable pressure ulcers or injuries. If on my first skin assessment on day 1, a known pressure ulcer or injury is covered with a non-removable dressing, that is what I would code for the start of care OASIS, even if the dressing is removed, allowing staging of the wound by day 3 or 4. Always code based on the first skin assessment. Let's practice applying that guidance with a patient scenario. On the start of care visit, a nurse observes a stage 3 pressure ulcer over the trochanter. At the next visit, 2 days later, the same nurse observes the same location, and now it's a stage 4. How would this wound be coded at start of care? Would it be a stage 1, a stage 2, a stage 3, or a stage 4? We can immediately eliminate options A and B because at no point in the scenario is a wound reported as a stage 1 or 2. We do, however, have documentation that the wound was a stage 3 at the start of care visit and 2 days later had become a stage 4. Applying the guidance to code based on the first skin assessment, we would code this wound as a stage 3 because that was the stage observed during the first skin assessment, even though it did worsen to a stage 4 within the 5-day start of care assessment time frame. various questions have been submitted to the CMS Home Health Quality Help Desk about how to address situations where a patient refused or declined a skin assessment during their start of care visit. Two Q&As from July 2019 provide insight to assessing clinicians to help with those types of situations. As previously discussed, the first skin assessment should be conducted as close to the start of care date as possible. However, there may be times when this does not occur. For example, when that patient declines the skin assessment on the start of care date, but then they allow a skin assessment on a subsequent visit, maybe by a different clinician. The original assessing clinician may collaborate with a second clinician who did in fact conduct the first skin assessment and use information from that second clinician's documentation to code the pressure, ulcer, or injury items on the start of care OASIS. It's important to note that OASIS guidance restricts us from coding or staging a pressure, ulcer, or injury by solely referring to documentation from a prior care setting, like information documented on hospital discharge paperwork. Being able to accurately stage a pressure, ulcer, or injury is important in order to code the pressure, ulcer, or injury items on the OASIS. There may be times when clinicians are unsure which stage or type of unstageable pressure, ulcer, or injury a wound should be coded as. An example of this pertains to deep tissue injuries, or DTIs. A DTI is defined as a purple or maroon localized area of discolored intact skin or blood-filled blister that's due to damage of underlying soft tissue that was caused from pressure and or shear. These wounds can progress rapidly, so there may be situations where a DTI begins to open and demonstrate tissue loss, but still present with that localized purple discoloration that's characteristic of a DTI. When this happens, the DTI will continue to be considered a DTI if the tissue loss is just partial thickness. So an area of purple localized discoloration due to pressure presenting with partial thickness tissue loss would still be reported as a DTI. However, if the purple localized discoloration, characteristic of a DTI, is presenting with full thickness tissue loss, the wound would no longer be considered a DTI and instead would be staged based on visualization of the wound bed. For instance, it would be coded as a stage 3 or a stage 4, depending on what is observed in the wound bed. Considerable additional guidance to support coding of DTIs and other pressure, ulcers, and injuries is available in the OASIS guidance manual. As previously mentioned, at the discharge time point, M1311 reports not only the current number of pressure, ulcers, and injuries present at each stage, but also which of those present at discharge were also present at the most recent start of care or resumption of care, also sometimes referred to as present at the most recent SOC-ROC. For a pressure, ulcer, injury to be considered present at the most recent SOC-ROC, the pressure, ulcer, or injury present at the discharge assessment would have to have been observed at the same stage at the most recent start of care or resumption of care. So if a patient has a stage 3 on their right elbow at discharge, and we also observed a stage 3 on their right elbow at start of care, we would report this stage 3 at discharge as being present at the most recent SOC-ROC. This determination can be fairly easy in situations where a pressure ulcer is stageable at both the start of care and at discharge. In the real world, that's not always the case. So let's take some time to review some situations where the wound is unstageable at the beginning or unstageable at the end of the quality episode. The guidance manual instructs us that any pressure, ulcer, or injury that is observed at discharge to be unstageable due to slough or eschar that was previously numerically stageable is considered new and would not be coded as present at the most recent SOC-ROC. So to rephrase, for any quality episode where we have a stageable pressure ulcer that ends up unstageable due to slough or eschar at discharge, it's considered new and not coded as present at the most recent start of care or resumption of care. Another scenario that agencies have asked about is what to do when a pressure ulcer that was present at the start of care healed during the episode, but then reopened again at discharge. For example, a patient has a stage 3 at the start of care, it heals, but then reopens due to pressure to a stage 3 at the time of discharge. Is that stage 3 at discharge considered present at the most recent start of care resumption of care? And the answer is yes. In the case where the stage 3 that's present at discharge was observed as a stage 3 at the start of care, same stage, same location, it would be considered present at the most recent sock rock, even in cases where it heals and then reopens during the episode. All right, now that we have reviewed the definition of present at the most recent start of care resumption of care and some special coding circumstances, let's look at 4 scenarios to determine which of these would be considered as present at the most recent sock rock. Scenario A describes a stage 3 pressure ulcer at the start of care that ends up as a stage 4 at discharge. This is an example of a pressure ulcer that has worsened during the quality episode. It's not the same stage at discharge as it was at the start of care. So we would not consider it present at the most recent sock rock. Scenario B is a stage 3 at start of care that is unstageable due to slough and eschar at discharge. Remember that if an unstageable pressure ulcer due to slough or eschar that's present at the time of discharge was ever numerically stageable during the quality episode, it would be considered new and not be considered present at the most recent sock rock. Scenario C is a DTI at start of care that became a stage 4 and then was unstageable due to slough and eschar at discharge. Remember again, anytime we have a stageable pressure ulcer that ends up being unstageable due to slough and eschar at discharge, it's considered new and not coded as present at the most recent sock rock. Our final scenario is D, and it's an example of a stage 3 pressure ulcer at start of care that healed during the episode, but then reopened as a stage 3 at discharge. Would this stage 3 at discharge be considered present at the most recent sock rock? And the answer is yes, because the stage at discharge is the same stage as it was at the start of care, even though it had healed and reopened due to pressure during the quality episode. So that covers the new guidance related to coding some of the more complex pressure ulcer or injury situations that providers have sought clarification on. Let's move on to the next OASIS item we'll review today, which is M2420, Discharge Disposition. Again, this presentation is intended for learners who have a good working knowledge of this OASIS item, including the definition of formal assistive services as outlined in the guidance manual. M2420, Discharge Disposition, is collected at the discharge time point, and it is used to describe the services that a patient will be receiving after they're discharged from your agency. For the purposes of this presentation, we're going to specifically look at new coding guidance that affects response 1, patient remained in the community without formal assistive services, and response 2, patient remained in the community with formal assistive services. Before we review the updated guidance, let's first talk about why a guidance change was necessary. One of the new Impact Act quality measures that will start data collection when OASIS E is implemented is the Transfer of Health Information to Providers measure. This measure will report the proportion of patient stays where a current medication profile was provided to the subsequent provider at the time of transfer or discharge from your agency. In order to collect the data as intended for the measure, the definition of formal assistive services for M2420 needed to be redefined. Response 1 of M2420 indicates that the patient remained in the community without formal assistive services. The updated guidance redefines response 1 to now include any kind of assistive services except care by another Medicare certified home health agency. So some of the discharge situations that would now fit the intent of response 1 include patients who reside in assisted living or board and care housing, patients who receive community-based services such as homemaking services under a Medicaid waiver program, personal care services, paid care provided by an individual, and community programs like Meals on Wheels. Please note that this definition is new. Previously, all of these services would have been considered formal assistive services and would have been coded with response 2. Response 2, patient remained in the community with formal assistive services, will now only be selected if at the time of discharge from your agency, the patient will begin receiving skilled services from another Medicare certified home health agency. Choosing response 2 will then trigger the clinician to answer these items that will be used to calculate that new transfer of health information to providers quality measure. Let's review a few different discharge situations to determine if response 2, patient remained in the community with formal assistive services, should be coded. The first scenario is a patient that you're discharging and they'll remain in their home with family caregivers. This would not be coded as response 2 since the patient won't be receiving home care services from another Medicare certified home health agency. Scenario B is a patient who will be receiving personal care in the home from paid caregivers. While this would have previously been considered formal assistive services, we would now consider this type of services as not formal, and so it would not be coded as response 2. Scenario C is a patient who will be remaining in the home with help from church friends. As we've been discussing, since there's no indication that the patient will be receiving skilled care from another Medicare certified home health agency, this is not a scenario where response 2 applies. Scenario D describes a patient who, after discharge from your agency, is going to remain in their assisted living facility apartment and will be receiving skilled care from another Medicare certified home health agency. While an assisted living facility in and of itself is not considered a formal service, because the patient will be receiving skilled care from another Medicare certified home health agency, response 2 would be selected. For the remainder of the presentation today, we will cover guidance related to GG0130 self-care and GG0170 mobility activities. And for that, I'm going to turn the webinar over to Megan to cover these items.
Thank you, Linda. So this section of the presentation is intended for learners who have a good working knowledge of these OASIS items, including the item intent for each functional activity, criteria for code selection using the GG coding scale, and the response-specific instructions and coding conventions for the GG items. GG0130 is made up of 7 specific self-care activities, and GG0170 consists of 17 mobility activities. These items were added to OASIS in 2019 with OASIS D, and multiple quarterly Q&As have been published to clarify coding of these new items. Before we review the guidance updates, let's first review the GG coding scale. The GG activities are unique in that every activity is coded using the same coding scale. There is a set of 6 performance codes, 0, 6 independent through 0, 1 dependent, that are used to indicate the type and amount of assistance a patient requires to complete an activity. There are also a set of 4 activity not attempted codes, 0, 7, 0, 9, 10, and 88, that are used to indicate the reason why an activity could not be completed and the performance code could not be determined. When assessing a patient's ability to complete the GG activities, CMS has provided a variety of assessment strategies that can be used to determine a performance code. The first strategy is observation. Directly observing the patient complete the activity is the preferred method in determining a patient's ability, but there are times when observing an activity may not be possible. When direct observation does not occur, rather than reporting an activity not attempted code, clinicians are instructed to to attempt to determine a performance code by using other assessment strategies. Available assessment strategies include coding based on reports from the patient or their family, or collaboration with other agency staff that have seen the patient during the assessment timeframe. The assessing clinician may also determine that the patient's status of an activity can be determined based on the type and amount of assistance the patient needs to complete a similar activity. Using one or more of these allowed assessment strategies will serve to minimize the use of an activity not attempted code in favor of a performance code, which provides a more valuable representation of the patient's status in a given self-care or mobility activity. While CMS does not provide specific parameters or a complete list of acceptable proxy activities, providers are expected to use clinical judgment in determining if observation of a similar activity allows the clinician to adequately determine the type and amount of assistance required to complete the intended activity. Clinicians familiar with OASIS will know that for some of the M1800 ADL, IADL function items, a more dependent code is selected when a patient requires an assistive device to complete a task. For instance, the patient who walks with a cane is reported as more dependent on M1860 compared with a patient who walks safely without a cane. This coding impact based on the use of assisted devices is not the case for the GG function activities. The GG activities may be completed with or without assistive devices. If an assistive device is used, it does not result in more dependent coding being selected, and in fact, use of a device may result in the patient being more independent. It is important to understand that at the start of care or resumption of care, the code selected for a GG activity ideally would reflect the patient's baseline status, meaning what was the patient's ability to complete the activity based on a functional assessment that occurred at or soon after the patient's start of care or resumption of care and prior to the benefit of services. The definition of prior to the benefit of services is prior to the provision of any care by your agency staff that would result in more independent coding. The phrase prior to the benefit of services replaces an older phrase prior to the start of therapy services that is found in the guidance manual, as CMS acknowledges that it is not just services from the therapy disciplines that can cause a patient's functional status to improve. It can sometimes be difficult to determine a patient's baseline ability prior to them benefiting from services, especially if some type of instruction or intervention is needed in order for the activity to even be assessed. For example, if I'm introducing a cane to my patient for the first time, it might be difficult for me to assess the patient's ability to use the cane without providing some type of instruction, cueing, or actual assistance. It's important to understand that for OASIS coding purposes, simply introducing a new device should not automatically be considered as providing a service. Likewise, communicating an activity request, like asking a patient to walk to the door, would also not automatically be considered providing verbal cues or assistance. It is appropriate to assess a patient completing an activity using an assistive device that is new to them and selecting a performance code. If a device is new to a patient, we would still have the patient complete the activity, providing assistance as needed, and then select their performance code based on the type and amount of assistance the patient required to complete the activity. To determine the patient's baseline status, a clinician could first have the patient attempt an activity prior to providing any instruction that could result in a more independent code. As needed for safety, provide whatever verbal cueing or assistance is necessary in order for the patient to complete the activity safely. Then code the activity based on the type and amount of assistance that was required during that attempt. Let's put this into practice with a scenario. At start of care, even with assistance, a patient was not able to go up and down steps secondary to safety deficits. After 2 therapy visits, the patient was able to go up and down 4 steps with moderate assistance. In this scenario, which code reports the patient's baseline status? Is it code 03, partial moderate assistance, or code 88, not attempted due to medical conditions or safety concerns? The correct answer is code 88, not attempted due to medical conditions or safety concerns. The patient's baseline ability prior to the benefit of services was that they were not able to go up and down the stairs. It was only after the benefit of the 2 therapy visits that the patient's status improved from baseline. For most OASIS items, including the GG function items, the time period under consideration is the day of assessment. This is defined as the 24 hours immediately preceding the assessment and the time spent by the clinician conducting the assessment. When using the assessment strategy that allows coding based on patient or caregiver report, it's important to remember that the report should be based on the patient's status during the time period under consideration. This means that if we were coding the bathing activity based on feedback from a caregiver, we would want the caregiver to be describing the type and amount of assistance that the patient needed to bathe today or within the past 24 hours, not a week ago or before they were hospitalized. Another assessment strategy we've discussed is collaborating with other agency staff to determine a patient's performance. When using collaboration, each person contributing to the collaboration may have their own day of assessment. For example, a nurse performs a start of care visit on Monday and is with the patient from 1 p.m. to 2:30 p.m. The nurse's day of assessment is Sunday at 1 p.m. through Monday at 2:30 p.m. That is 24 hours before their visit, plus the time they are conducting the visit. If a physical therapist visits the same patient on Wednesday from 10 a.m. to 11 a.m., the PT's day of assessment would be Tuesday at 10 a.m. through Wednesday at 11 a.m. Let's take some time to review guidance for a couple of the GG performance codes. First, let's look at code 04, supervision or touching assistance. This code is used when a patient requires a helper to provide supervision or touching assistance and or verbal cues and or contact guard steadying assistance as the patient completes an activity. This code would also be used if a patient requires a helper to manage an oxygen tank or tubing while also needing contact guard assistance while the patient completes an activity. Code 01 dependent has 2 different applications. The first situation when 01 dependent is used is when a helper is required to provide all the effort needed to complete an activity. The second situation, which is the issue this clarification on slide 43 addresses, is when 01 dependent is used because a patient requires the assistance of 2 helpers in order to safely complete an activity. Code 01 would be used even if the second helper is required to provide supervision or standby assist, but does not have to provide hands-on assistance while the patient completes the activity. The required presence of that second helper meets the definition of code 01 dependent. We've mentioned earlier that in addition to the 6 performance codes, the GG activities also have 4 activity not attempted codes. These codes are used to explain the reason why an activity was not completed. Activity not attempted codes should be used when, at the time of the assessment, the patient is unable to complete the activity, and the performance for that activity cannot be determined based on patient or caregiver report, collaboration with other agency staff, or assessment of similar activities. In situations where the activity is not completed and a performance code cannot be determined based on the available assessment strategies, the assessing clinician would determine which activity not attempted code is most appropriate. Code 07 is used if a patient refused to complete the activity. However, the guidance directs us to only use the 07 patient refused code when the patient refused to complete the activity and no other performance or activity not attempted code is applicable. To rephrase this, if more than one activity not attempted code applies, code 07 patient refused is the last activity not attempted code a clinician should select. We have discussed several assessment strategies that can be used when assessing a patient's ability to complete an activity. Clinicians may be faced with a situation where a patient only completes part of an activity. For example, when assessing bathing, the patient will only agree to wash their chest and arms. Or we get caregiver report of the patient's ability to dress themselves, but not undress. In these situations, use clinical judgment to determine if the situation allows adequate assessment of the patient's ability to complete the activity. If by using clinical judgment, the clinician determines that the observation was adequate to allow coding of the target activity, then code based on the type and amount of assistance that the patient would require to complete the entire activity. Let's now move away from the more general GG coding guidance and focus the rest of our time on guidance updates for a few of the specific GG 0170 mobility activities. As a reminder, this presentation is intended for learners who have a good working knowledge of these GG items, including the item intent for each functional activity and the coding scale. Let's review guidance clarifications for the items highlighted on this slide. Lying to sitting on the side of the bed, car transfer, the walking activities, the stair activities, and finally, GG 0170Q, does patient use wheelchair and/or scooter? Let's start with GG 0170C, lying to sitting on the side of the bed. When first introduced, the intent of this activity was to assess and code the patient's ability to move from lying to sitting on the side of the bed with feet flat on the floor and no back support. Based on this item intent, the help desk received many questions from providers asking if an activity not attempted code would have to be used if the patient's feet were not flat on the floor, perhaps because of the patient's height, the height of the bed, or because the patient was a bilateral amputee. A quarterly Q&A in January 2019 provided the guidance update that as long as the patient could perform the activity of sitting on the side of the bed with no back support, then a performance code could be selected. In fact, the phrase feet flat on the floor has been removed from the OASIS E draft dataset. GG 0170G car transfer assesses the patient's ability to transfer in and out of a car or van on the passenger side. It is important to understand that this activity focuses on the transfer in and out of a car or van seat. Meaning, if we have a patient who transfers into a van in a wheelchair and never transfers into the seat of the van then the activity is not completed and the appropriate activity not attempted code would be used. Guidance was also published to allow clinicians to assess this car transfer activity from any vehicle model that might be available. So in addition to a car or van, the car transfer activity may be assessed with the patient transferring in and out of a seat in an SUV or a truck. The most recent update to the car transfer guidance was published this past April. The new guidance instructs clinicians to use their clinical judgment to determine if a transfer in and out of the back seat of a car allows the clinician to adequately determine the type and amount of assistance required to complete the car transfer activity, and if so, choose the appropriate performance code. Also, if there is a patient who must sit in a long sitting position due to a medical restriction, the car transfer can still be completed. Let's now review some guidance updates for the GG walking activities. Walk 10 feet, walk 50 feet with 2 turns, walk 150 feet, and walking 10 feet on uneven surfaces. When assessing a patient's ability to walk each of stated distances, it is appropriate to allow the patient to take a brief standing rest break or a breather if needed during each activity, and still consider the activity as being completed. Now, if a patient must sit down to rest partway through a specific walking activity, then we would not consider the activity as being completed and may be choosing an activity not attempted code. Another scenario where we would consider a walking activity as not being completed is if the patient requires a helper to carry them either all or part of the stated distance. A helper cannot complete a walking activity for a patient. A walking activity cannot be considered complete without some level of patient participation that allows the patient to walk for the entire stated distance. Now let's look at some guidance clarifications for use with the stair activities of going up and down 1 step or a curb, up and down 4 steps, and up and down 12 steps. We all know that patients can come up with unique ways to get things done, including unique ways of getting up and down stairs. The intent of these items is to determine the amount of assistance that a patient requires to go up and down the stairs by any safe means. This could include patients who go up and down stairs on their feet, patients who scoot up and down the steps on their bottom, as well as patients who use a stair lift as a way to go up and down stairs safely. Remember when we discussed the use of an assisted device? We said that a patient may use assisted devices or equipment that allows him or her to safely complete an activity as independently as possible. The last guidance update that we will cover today is for the wheelchair activities. Specifically, how to code GG0170Q, does patient use wheelchair and/or scooter? This is a yes or no item and serves as the gateway question to the rest of the wheelchair items and activities. Code 1 yes for GG0170Q when a patient uses a wheelchair and/or scooter at the time of assessment. This would include patients who are learning how to self-mobilize, patients who require assistance from a helper to mobilize using a wheelchair, and patients who require a helper to push them in a wheelchair. In fact, the guidance says that code 0 no should only be used if at the time of assessment, the patient does not use a wheelchair or scooter under any condition. Since code 0 no is a patient who does not use a wheelchair or a scooter, selecting no results in skipping over coding the remaining wheelchair activities. So that concludes our overview of the OASIS Interim Guidance. Slide 60 includes a list of references that we've mentioned or that relate to guidance addressed during this presentation. We will now turn it back to Haley.
Okay, thank you, Megan. Before we wrap up, let's cover some questions. Our first question is about M1033, risk for hospitalization. If a patient is refusing to take some or all of their medications, but the physician instructs the nurse to keep the medications on the reconciled medication list, how would that impact M1033 response 7?
Yeah, I'll take that question. As we discussed, M1033, risk for hospitalization, that response 7 looks at the number of meds that the patient's currently taking to see if they're taking 5 or more medications. That number is determined based on how many medications are listed on that reconciled medication profile. So if the physician instructs the agency to maintain 5 or more medications on the reconciled medication profile, then we would consider the patient to be taking 5 or more medications.
Thanks, Linda. Here is another question. The Q&A about only completing a partial activity gives the example of a patient only completing a partial bath. Does this guidance concept about coding based on partial completion of an activity also apply to other GG activities like a car transfer?
This is Megan, and I'll take this one. The answer to this question would be yes. If we only observe a patient completing any part of any of the GG activities, with the exception of walking, we can choose a performance code as long as we determine that our assessment, which included observation of the partial activity, is adequate to allow us to determine the type and amount of assistance the patient requires to complete the entire activity. So, for example, with a car transfer, there may be instances where we only see a patient transfer into a car and not out. If, using our clinical judgment, we determine that this observation allows us to adequately determine the type and amount of assistance the patient requires to complete the entire car transfer, then we would code GG0170G with the appropriate performance code.
Great. Our next question is, there are quarterly Q&As that say that you can complete the GG stair activities using a stair lift, but in the guidance manual, it says that if a stair lift is used, then the activity was not completed.
I'll take this one too. So this is really a great question because it highlights the fact that in situations where CMS makes refinements or updates to the guidance, until there's an opportunity to update all the resources, there may be periods of time where conflicting guidance is posted. In such cases, clinicians should use the most recent guidance. Thanks so much, Megan. I'll just add that all of the OASIS guidance published has a date, whether it is the guidance manual or the quarterly Q&A. So in those cases where we need to make some clarifications, refinements, or even redefine a response option like we're doing with M2420, you should rely on the guidance that's published with the most recent date.
Thank you, Megan and Jemima. Okay, our next question is, if a patient is going to be receiving both Meals on Wheels and skilled home care services from a Medicare certified home care agency, which response do we select for M2420? It seems that both response 1 and response 2 could apply.
Yeah, this is Linda. I can take that. That's a good question. So for 2420 discharge disposition, we discussed that the guidance response options 1 and 2 have been updated. You can only select one response. So anytime you're discharging a patient from your agency and they're going to be receiving skilled services from another Medicare certified home health agency, you'd select response 2, that they are remaining in the community with formal services. And this is going to be true even in cases where, in addition to the formal services from that certified agency, the patient is also going to be receiving support that's now defined as informal services like Meals on Wheels. So just report response 2, not both.
Excellent, thank you. And I believe we have one more question. We are looking to provide more training to our staff on OASIS guidance for pressure ulcers and GG activities. Is there a place to find any scenarios or CMS videos or trainings that can help with that?
I'll take that. This is Jemima. There are some great coding examples for both pressure ulcers and the GG activities in Chapter 3 of the OASIS Guidance Manual, which could be useful in training your clinical staff. Also, one of the links listed on the previous resource slide is for the Home Health Quality Reporting Training webpage. And this site contains various training modules that can be used for OASIS training, and you might find content on that site that will support your staff education needs.
Thank you very much. That is so helpful. And this concludes our webinar. Thank you for participating in the training. We hope it has been valuable to you in highlighting the OASIS Interim Guidance. We want to thank our presenters, Jemima Keys, Linda Krulish, and Megan Bernier, for sharing their knowledge and expertise with us. As a reminder, if you have additional questions now or in the future about any of the content reviewed today, please submit your inquiry to the Home Health Quality Help Desk at homehealthqualityquestions@cms.hhs.gov. This concludes the OASIS Interim Guidance webinar. We hope everyone has a great day.